So two things I thought would be good to talk about today. One is a report of a cluster outbreak that happened in a hospital in Hong Kong that I think illustrates pretty well a lot of the different things that we've talked about on some of these calls and experts have been communicating, but I think, again, it's helpful to reiterate these things. So this is a report. It came out just recently about an outbreak again at a hospital in Hong Kong. And again, remember, Hong Kong has had a very low rate overall of COVID-19 cases. So these types of outbreaks are unusual. And also Hong Kong has a very well-developed public health system to investigate these things. So they're able to get a better picture exactly of what happened in these types of events. So this was an event that involved 12 patients and 9 healthcare workers in one section of a relatively, as they say, old-fashioned layout of a hospital, although even though the layout may be old-fashioned, people, I think, obviously know that Hong Kong has an incredibly modern and sophisticated healthcare delivery system. And so their infection prevention control practices are every bit as good as ours, if not better. So this outbreak, again, I think illustrates a couple of things. First of all, the index patient that was eventually identified, P2 here, was admitted on the 15th of December in 2020 and tested negative by PCR upon admission, but clearly transmitted disease within the first 6 days of admission without being recognized as having developed COVID-19 or at least shedding virus. And again, highlights the fact that we know that our PCR diagnostics, even though they're the best we have, are not always 100% effective, and that people can be PCR negative and actually not shedding virus, but several days later become infectious and shed virus even without manifesting symptoms. And that's what happened in this particular event that kicked off this ultimate outbreak. I think the other thing to note is that this cluster was associated with patients and healthcare workers in these cubicles, as they call them. These are 6-bed alcoves of where patient care is delivered in the inpatient wards in this hospital. I think very important to note that the highest risk was obviously in patients that were housed close together to other infected patients, particularly P2, who appeared to be a super spreader and probably was responsible for the vast majority, if not all, of the secondary cases. All of these cases were linked genomically as a single cluster, so we know that they're all related. What's interesting is we also know that in addition to patients who were housed together in the same cubicle, this one patient, patient 12, in an adjoining cubicle, and also patients that were housed only in the hallway in temporary bed positions, you can see 39E and 3E circled there, were also infected. And that healthcare workers that cared for these patients had a much higher rate of infection than healthcare workers elsewhere in the hospital. You can see 2 out of 109 elsewhere, 1.8% versus 7 out of 68 that worked on that ward, 8%. And also risk correlated with how much time they spent delivering patient care in those cubicles. I think also important to note that 6 of the 12 patients who eventually ended up diagnosed were completely asymptomatic. And again, this is something that we have recognized that asymptomatic infection can be quite common. Important to note again that the hospital was following very stringent COVID-19 protocols, including universal masking for everyone, and significant hygiene practices, hand washing, surface cleaning, et cetera, et cetera. Nevertheless, they had this relatively large cluster, and you can postulate that perhaps this was the result of direct contact with nursing staff or contamination of environmental surfaces. But I think that the data don't necessarily point to that. As you can see, only 3% roughly of the surface samples that were collected from various places around the beds and around the cubicles and ward tested positive. But 6 out of 9, or 67% of the exhaust air grills in this area of the hospital tested positive. So clearly, the intake air grills where the air exhaust is drawn in was a very hot surface, and it was noted that the air grills were located away from the cubicles, not in the cubicles. So the air circulation in the cubicles themselves was actually pretty poor, as I think one can see based on the clustering of transmission in those cubicles. So again, I think just highlights things that we already know, that the transmission occurs in clusters, that transmission occurs via primarily the airborne route, that super spreaders can be responsible for significant clusters, particularly environments where people are more closely gathered in proximity in congregate settings, and that asymptomatic infection is common, and that even in the presence of asymptomatic screening, as was done for admissions into the hospital, you don't pick up all of the cases unless you're testing and screening every day. So some important lessons there. The second thing that I thought was good to talk about was an article that came out a couple of weeks ago in JAMA and looked at all-cause mortality in the US for 2020. And this made a little bit of a headline when it came out, showing that COVID-19 was the third leading cause of death during 2020, which I don't think should surprise anybody, but I think is also important to know when we're confronted by many folks who are still in this ways of disinformation campaigns, thinking that all of these COVID deaths are made up. And it's even more striking if you take the annual COVID-19 mortality from the beginning of May in 2020 to the beginning of the beginning of April to the beginning of April. You can see that that death toll was over 560,000. So really on par and at the same level as mortality from cancer, which is the second leading cause of mortality in the US, and very close to the overall leading cause of death in the US, which is heart disease. And so, this idea that the pandemic is overblown is ludicrous when you think of the number of Americans we've lost in the last year from COVID compared to what we normally expect overall. And this is borne out by CDC data and data from the National Center for Health Statistics, looking at the overall excess mortality that occurred during 2020 and into 2021 associated with the COVID-19 pandemic. If you look over on the left, you see in 2018, there's a small period where deaths exceed the upper limit of what would be statistically normal bounds. And that was the worst seasonal influenza season we've had in the past several decades. And so that's what a really horrendous seasonal flu looks like versus what we see on the right, which is what COVID-19 looked like. And I think it's important to understand the magnitude of those excess deaths. So you can think about whether COVID-19 was correctly diagnosed or not as a source of mortality. But the reality is we've lost well over 600,000 excess mortality deaths over the last year and couple of months. And clearly the only thing that's changed is the pandemic. The magnitude of that is really impressive when you look at some of the peak weeks where we can see over 40% excess mortality in the first week of January 2021. And also, I think important to recognize that many of these excess mortality deaths are other diagnoses outside of COVID-19. So again, we've got the 560,000 COVID deaths over the last year. That's a given. But what's also true is we've actually had many more deaths due to these conditions, particularly circulatory diseases, strokes, heart attacks, Alzheimer's and dementia, as you can see. And what this probably means is that these are miscoded or at least misclassified deaths that probably have a root cause in COVID-19 that they just weren't recognized, again, because of some of the vagaries of testing that we just talked about with this previous case, right? So you have a patient who's admitted from a nursing home or who dies in a nursing home with Alzheimer's disease, and that's attributed to their Alzheimer's or dementia. And maybe they had a negative COVID test at some point during the course of this illness. perhaps they didn't because of no underlying suspicion. But the reality is that death was potentially precipitated by COVID-19 infection. We know that clearly is the case in many instances of thromboembolic disease like strokes and heart attacks, which we know is that risk is increased by COVID-19. So the bottom line is probably many of these additional excess deaths that are not counted as COVID are really underlying COVID. And that's what we know about influenza as well. We don't primarily count all of the deaths from influenza because we often don't diagnose flu as the precipitating event for clinical decline. So those two things I think are important to keep in mind when we're communicating with folks in the lay public who, again, are often quoting really bad information that they read off of the internet. So that's all I have. Thanks, Shelley.